Hello everyone. Previously we have discussed the endodontic diagnosis, and then we have moved to the pulp and preapical conditions, or the state of the pulp and preapical lesions. So today we are going to discuss a new topic, which is about the endodontic emergency. So one of the critical cases that should be properly managed in the dental clinic, which is the endodontic emergency. Mostly this patient, he comes to my clinic complaining of pain and or swelling. With this patient, he needs a proper diagnosis and a definitive treatment for this case. Mostly you will find that this patient, he cannot do his daily activity. Mostly you will find that this emergency, it have started a few hours ago. Mostly you will find that the patient have taken a lot of medication, and these medications or these analgesics or painkillers are not working. So this can be characterized or characteristics of the endodontic emergency. Endodontic emergency, it can be classified into three types. The first one is the pre-treatment emergency. The second one is the inter-appointment emergency, and the last one is the post-operative or the post-obturation emergency. For management or for successful management of the endodontic emergency, I need properly to control the pain, because mostly the patient, he comes to my clinic complaining of pain. So I need to deliver a proper and profound anesthesia. This could be done by psychological approach or giving a proper local anesthesia. This in the maxillary teeth, mostly we give infiltration, and for the mandibular teeth we give inferior alveolar, and sometimes we need in the mandibular teeth, we need like supplemental anesthesia like the intraosseous, intraligamental anesthesia or intrapulpal anesthesia. So let's go for the pre-treatment emergencies. The first case is the symptomatic irreversible pulpitis without apical periodontitis, or you can say with a normal apical tissue. As we mentioned before, it will be characterized by a lingering pain, spontaneous pain, a dull aching spontaneous pain, exaggerated response following a stimulus like cold or hot, and lingering response. Okay, pain, it can increase while the patient, he starts to lie down, especially he starts to sleep due to the intracephalic pressure that is going to the head. This will increase the intrapulpal pressure. Referred pain and diffuse pain, the patient has difficulty in localizing which tooth, is it upper or lower, okay? Also, during the radiographic examination, the patient, you will see nothing. You will see no bone rarefaction or no bone changes or no radiographic changes in the preapical X-ray. Okay, mostly this case also it is characterized by there's no pain on percussion. Why there's no pain to percussion? Because the inflammation has not extended yet to the periapical ligaments. So the inflammation is confined mostly in the pulp chamber. So as the inflammation is confined only in the pulp chamber, I can start by extirpating the pulp tissue, doing profound anesthesia, access cavity to this case. If I'm talking about an anterior teeth, it's easy to extirpate the pulp tissue as a whole, okay? But if we can't, if we have a limited time, as for example, cases of molars, okay, I can just do pulpotomy, which is deroofing of the pulp chamber and removal of the content of the pulp chamber. This will be followed by irrigation by our default irrigation, of course, which is the sodium hypochlorite. And after finishing, I will prescribe analgesics for this case, as for example, 400 milligram of ibuprofen or 500 milligram of acetaminophen. So the other case, it will be symptomatic irreversible pulpitis with symptomatic apical periodontitis. So as I mentioned, symptomatic apical periodontitis, so the inflammation here have extended to the periodontal ligaments. So the treatment, it should include total removal of the pulp tissue from the pulp chamber and from the root canal to make sure that I have removed all the irritant from the root canal systems. Okay, mostly this case, it will come to my clinic complaining of what I have mentioned before, all the characteristic features, in addition to pain on percussion or pain on mastication. So again, the treatment, it will be pulpectomy, removal of the whole pulp tissue, and I can also just reduce the functional cusp to decrease the post-operative pain or to decrease the apical periodontitis happening. Another condition is the pulp necrosis without swelling. Most of the cases of the pulp necrosis, it will not, I cannot say it's an emergency treatment. It's an emergency cases. But some of the cases, whenever there's an extension of the bacteria to the periodontal ligament, it starts formation a periapical lesion. Okay, so our treatment here, it will be a removal of the pulp irritants from the root canal system and relieve the pressure that is occurring in the apical region by drainage of any irritants or drainage of any pus that have been formed in the periapical area. So management of these cases, it will start by access cavity preparation, of course, canal debridement. Debridement here means removal of the irritants from the root canal system. It's preferred to go for a crown down technique to start preparation coronal, then middle, then apical, to avoid pushing the irritants or the microorganisms to the apical, through the apical foramen. I can put calcium hydroxide between visit to decrease the bacterial population in the root canal. If I have a case with a pulp necrosis with a localized swelling, okay, so I need here start first by doing access cavity, okay. During access cavity, some cases it drains the pus from the root canal due to the pressure in the periapical lesion. Some of the cases it will not. Some of the cases I need to negotiate or violate the apex. Okay, by a small file, I can extend my preparation or extend my filing beyond the apical constriction up to file 25 or maximum 30. Okay, to ensure drainage of the pus. If I can do that, and if I have a fluctuant swelling, and if I can do, if I need to do drainage from the soft tissue, I will start by doing incision and drainage by scalpel size 11 with a step incision and relieving the pain and relieving the pus from the this periapical lesion and putting a drain to ensure drainage from the from the soft tissue. Another condition, if I have pulp necrosis with diffuse swelling, like for example a cellulitis cases, this cases mostly the infection has spread to the facial spaces. Okay, there will be elevating in the temperature. There will be sometimes limited mouth opening or trismus. The spread even or the infection, it can spread bilaterally. Okay, so in the management of this case, I will try to debride the canals, to open access cavity, debride the canals. I can violate the apex to ensure drainage from the root canal, but most of these cases, it will not drain from the root canals, and this cases needs to be hospitalized and to do extraoral incision. Okay? Again, take it as a rule, don't leave the tooth open between visits. Okay? For any of these cases, we never leave the tooth open. What about the inter-appointment? Between visits, there could be emergency or post-operative pain between emergency or what we call flare-ups. What are the causes of these flare-ups? Mostly it occurs due to over-instrumentation, and this is the most common case. Okay, over-instrumentation, and this over-instrumentation, it can lead to pushing the debris beyond the apex. or incomplete removal of the pulp tissue, or leaving a missed canal, or over medication like over irrigation, or the irrigant have spilled out of the apical foramen, or hyper occlusion due to the high filling, for example. These cases, it can be divided into previously vital pulp with complete debridement. I have succeeded on removal of all the pulp tissue, and after that, mostly the patient come to my clinic complaining of pain post-operative. This is quite normal. Mostly during preparation, mostly periodontitis occurred due to pushing of some of the debris or pushing of the irrigants beyond the apex. Okay, you need to reassure your patient, give him non-steroidal anti-inflammatory, and just tell him to come back again to you. You can reduce occlusion between visits. Previously vital pulp with incomplete debridement. I haven't removed the pulp tissue from all the root canal. Maybe there's still some part of the pulp tissue inside the root canal. I need to recheck my working length, properly determine my working length, irrigate my canal properly by sodium hypochlorite, and seal again the canal and seal the pulp chamber by cotton pellet and dry cotton pellet and a temporary filling. A previously necrotic cases with no swelling. Here the case, it was previously necrotic and after the first visit, and this is very common. The patient came to me complaining from pain or swelling after the first visit. Here I'm going to manage the case again. As I mentioned, I'm going to debride again the canal. I'm going to irrigate the canal. If I can drain the canal from the apical foramen, it will be helpful to eliminate any pus that have been formed in the preapical lesion. I can give here, it's very important to give here non-steroidal anti-inflammatory. I can put calcium hydroxide in the root canal if I enlarge the root canal. Previously necrotic pulp without swelling. With swelling, the case with, I have started with the case with the previously necrotic with the swelling, and even after the first visit, the patient complained from the pain. I need here to drain the canal, again, either from the root canal, okay, as I mentioned, through violation of the apex, or I can do incision and drainage. One of the most common emergencies is the post-obturation emergency. I have finished my case in a single visit and I did my root canal. I did a proper root canal and it is satisfactory in the radiograph. Okay, I need to know why this happened. This is quite normal, again, due to irritation that happened during the instrumentation. I need to reassure my patient. I need to prescribe non-steroidal anti-inflammatory. If the patient came to me with a swelling, I need to do incision and drainage and non-steroidal anti-inflammatory. I can give antibiotics or I cannot give antibiotics. If I drain the pus, I no need to give antibiotics. Okay, pain and or swelling with an unsatisfactory radiographically case, this case need to be retreated again, either surgically or non-surgically. Thank you and see you in another topic.